Next, we have Dr. Altieri. Robotic approaches may offer benefit in colorectal procedures, more controversial in other areas. A review of 166,790 cases.
Thank you. We would like to thank SAGES, the SAGES Program Committee, for the opportunity to present our data here today. In addition, we would like to thank Dr. Bispo and Dr. Scott for moderating. Which one is the clicker? Okay. So we have no relevant disclosures. Since the introduction of laparoscopic cholecystectomy in 1988, laparoscopy has gained significant popularity in many surgical specialties. While advancement of minimally invasive surgery has increased significantly in certain areas, its penetration in other specialties remains suboptimal. More recent data from 2008 to 2012 from academic centers showed that penetrance of laparoscopy in colorectal surgery was as low as 52%, compared to other areas such as bariatric surgery, where it was 94%, and anti-reflux procedures, where it was 84%. And this is pretty impressive. The use of robotic-assisted surgery has been cited as a significant technological advancement in the area of minimally invasive surgery. While the penetrance of robotic surgery into fields of gynecology and urology has been significant, us as general surgeons have been the slower adopters. The purpose of our study was to compare laparoscopic and robotic-assisted surgery among 5 different general surgery procedures with various penetrance of minimally invasive surgery. Following IRB approval, the SPARCS database, which stands for the New York Statewide Planning and Research Cooperative System, administrative database, was used to identify 5 common general surgery procedures which were performed between 2008 and 2012. Namely, these were cholecystectomy, Roux-en-Y gastric bypass, esophageal fundoplication, colectomy, and sleeve gastrectomy. ICD-9 codes were used to select laparoscopic versus robotic procedures. Procedures were compared based on number of complications and hospital length of stay. Following univariate analysis, propensity score matching was used to estimate the marginal differences between patients who underwent robotic-assisted and laparoscopic procedures, with p-values less than 0.05 were considered significant. There were 1,458 robotic cases and 165,332 laparoscopic cases. From the robotic case mix, the majority were colectomy, followed by bariatric procedures, esophageal fundoplication, and finally cholecystectomy. Following univariate analysis, to our surprise, there were more complications following laparoscopic procedures compared to robotic procedures. However, when we further subdivided into the 5 categories, there was no statistical significant difference in terms of cholecystectomy, Roux-en-Y gastric bypass, sleeve gastrectomy, and esophageal fundoplication. Where the differences lied actually was in the colectomy group, where there was a higher rate of complications following laparoscopic procedures compared to robotic procedures. This was significant and impressive. Similarly, when we looked at hospital length of stay, colectomy and robotic colectomy had a lower hospital length of stay compared to laparoscopic procedures, as robotic procedures were mean of 5 days compared to laparoscopic procedures, which were mean of 7 days. Next, we performed propensity score analysis. Following propensity score analysis, again, there was a lower rate of complications following robotic procedures compared to laparoscopic procedures. When we looked at hospital length of stay following propensity analysis, actually there was no difference in hospital length of stay in the colectomy group, where the difference in now laid was in sleeve gastrectomy, where robotic surgery actually had a higher hospital length of stay compared to laparoscopic surgery, with a mean of 1.2 days. So based on these findings, we concluded that robotic-assisted surgery exhibited non-superiority to laparoscopy in common laparoscopic procedures in terms of complications and hospital length of stay. Robotic approaches may facilitate safer adoption of minimally invasive approaches in areas where penetrance of conventional laparoscopy is low, such as colorectal surgery. Thank you.
Again, any questions from the floor? My question is, was there any way of risk adjusting these cases at all, or is that beyond the capability of the database?
Well, we did propensity score analysis where we actually case matched, very similar on all characteristics.
Mm-hmm.
So patients that underwent laparoscopic surgery and robotic surgery were matched on most characteristics.
Okay. All right. Yes, question.
You spend, I think in the literature we see a lot of data that compares laparoscopy to robotic surgery, and we don't see the difference in the outcomes. I just was wondering if you could comment on the fact that do we need that, as you know, that laparoscopy and robotics being similar outcomes? I think that is a good thing rather than something that we're trying to prove over and over again. And looking at surgeon ergonomics and fatigability and things like that, I was just wondering if you could comment on that aspect of it.
Well, what we wanted to do is actually look into compare the different procedures that had different penetrance of laparoscopy. So that was our purpose. It wasn't exactly to compare just in terms of outcomes, but our variable was that these are 5 procedures that have different penetrance of laparoscopy.
Okay. Yes, sir.
Thank you for a great talk, Eric Dutson from UCLA. I just wanted to ask a question about the potential for selection bias when you're looking at these two things, because you imagine in cases where there's low penetrance of laparoscopy, the only people who are going to jump to the robot are ones who are probably well along on their learning curve for those particular procedures, and they feel comfortable enough to try something new. So I wonder if you had any thoughts on that. I'm sure when you were writing up your paper, that was one of the things you explained away in the discussion, I suspect.
It was, and it's actually, my mentor actually commented on that before this talk. We were talking about this. And there is, selection, there's a possibility of selection bias. We try to eliminate that as much as possible with the propensity score. Of course, there is no way to actually control for that. So we do need some prospective studies to actually evaluate this.
Thank you.
Yes, sir.
Steve DeMeester from USC. Very nice presentation. Question for you. Do you know what types of complications that occurred in the colorectal group? And then secondly, since they had a shorter hospital stay, there's always the concern that they had a higher readmission rate. There's been linkages between short hospital stays and readmissions. Does the database account for readmissions in colorectal patients that got discharged earlier?
So I'll answer actually your second question first. There is a way to actually look at readmissions, and that's great with the Sparks database. We haven't actually looked into that yet, but that's something that we can easily do. And your first question was if types of complications. So we actually looked into all complications, and this ranges from like gastrointestinal complication, which was a little more general, to more serious, such as myocardial infarction, leaks, etc. We haven't separated them yet, but that's something that we can do as well.
And I think one of the difficulties with these studies, of course, is to look at the experience of the surgeons doing these. We would have to assume, I think, that these were amongst the first robotic cases that these surgeons were performing in these various procedures.
So we didn't look to previous years. There is actually a way to look into whether the surgeon has done this because they have their NPIs in that database, but we haven't. We just concentrated on those 4 years.
Yeah. Okay. All right. Very good. Thank you very much.